I am Dr. Shiram, and today I'll be presenting this case of complex high-risk PCI in a terminally ill patient. So this is the tale of an 80-year-old male who is a known hypertensive and diabetic patient, and he has a stage 4 carcinoma esophagus. He underwent gastroesophagectomy about 2 years ago, followed by chemotherapy. And recently he was found to have metastasis in lungs and the bones. He had a past history of double vessel coronary artery disease with PCI to LAD and RCA in 2004. Now he presented to us with recurrent chest pain for the last 24 hours. On examination, he was an elderly cachectic male with a blood pressure of 110 by 70 millimeter of mercury, and his chest auscultation revealed occasional crackles at the bases with reduced breath sounds of the right base. An ECG revealed deep T-wave inversion in the chest leads consistent with the Wellens pattern, and the biochemical profile was unremarkable except for the raised troponin. His echo revealed moderate LV systolic function with ejection fraction of 40%, and there was mild pleural effusion on the right side. The coronary angiogram was done that revealed triple vessel coronary artery disease and the left mainstem disease. So this was the coronary angiogram of this patient. As you can see that there was a distal left main critical disease and the critical ostial disease in the circumflex and the critical disease in the ostium of the LAD. And there was also a clot that is visible in the ostium of the circumflex and the LAD. And this is another view that shows the critical disease in the left mainstem, and the stent in the LAD was patent. His LV sinus showed moderate LV function, and the right coronary artery revealed critical disease in the PDA. The case was discussed in the heart team meeting, and he was considered not suitable for CABG owing to the limited life expectancy and the metastatic carcinoma esophagus, having the bone and the lung mets. So he was placed on medical treatment and was observed in the coronary care unit. However, he had recurrent symptoms despite optimal medical treatment, including the heparin and the isocat infusion. After detailed discussion with the family, since his family, there were a lot of doctors, his daughter was a gynecologist and there were other doctors in the family, so they were also pushing about the intervention if any possible. So after explaining the risk and benefits, the high risk PCA was offered. Now, how to go about it? So after detailed deliberation and considering the definition criteria, since there was a distal left main bifurcation disease and the side branch stenosis was more than 70%, the lesion length in the circumflex was more than 10 millimeter. It also met the other criteria involving the thrombus containing lesions, and there was a chunk of calcium as well. So the DK crush was planned with the insertion of IABP, and the rota was considered to be in backup if at all needed. Anesthetists, perfusion and cardiac surgeons, they all were taken on board considering the very high risk PCI. So after IABP insertion, the 7th French sheathless entry was made using the XP3 guide. So this was the initial picture. Then the wiring was done, the BMW was parked in the circumflex and the run-through wire was placed in the LAD. And after wiring, this was the picture that showed the critical disease in the LMS, ostium, circ, and the LAD. Initial pre-dilatation was done with 2 into 15 millimeter balloon in the LAD. And the LMS to LAD, again, the pre-dilatation was done with the same balloon, and the circumflex was pre-dilated with another 2 into 20 millimeter semi-compliant balloon. The kissing balloon inflation was done with 2 15 millimeter balloon in LAD and 2 into 20 millimeter balloon in the circumflex. And this is on the right side, the picture after this kissing inflation. So considering the calcium and the possibility of difficulty in crossing the equipment across the into the LAD, so the non-compliant balloon pre-dilatation was done with 3 into 15 millimeter balloon in the LAD, and it was again the LMS was also pre-dilated with the same balloon, and the circumflex was also pre-dilated with the 3 into 15 millimeter non-compliant balloon. Then the stent was positioned across from LMS to circumflex with a crushing balloon parked in the LED. The stent was deployed. This was 3.5 into 23 millimeter stent in the circumflex, and the 3.5 into 15 millimeter crushing balloon was parked distally in the LED. This is the crushing balloon. After that, the circ stent was post-dilated with 375 into 20 millimeter non-compliant balloon. It was then crushed with the 3.5 into 15 millimeter NC balloon that was already parked in the LED. Later on, the step crush was done with 4 into 20 millimeter non-compliant balloon. This was the picture after the step crush, and then rewiring was done in the circumflex branch through the proximal struts. The strut opening was done with the 2 into 15 millimeter balloon, and after that the kissing balloon inflation was done with 3.5 into 15 millimeter NC balloon in circumflex and 375 into 15 millimeter non-compliant balloon in the LED. The initial circumflex wire was removed, and then after the kissing balloon inflation, you can see that there was a dissection in the left main stem. So immediately the stent was placed from LMS to LED. The stent is being positioned, and this, as you can see in this picture, this was the size of 3.5 into 38 millimeter stent that was deployed from LMS to LED, and this was the result after stent deployment. Later on, the port was done in the left main stem with 5 into 8 millimeter non-compliant balloon, and distal optimization was done in the LED. The LMS to LED stent was overlapping with the previously deployed stent, and this the dot was done with 375 into 15 millimeter non-compliant balloon. Circumflex was again rewired using another wire, and the previous circ wire was removed. Now the second kissing balloon inflation was done with 3.5 into 15 millimeter non-compliant balloon in the circumflex and 375 into 15 millimeter non-compliant balloon in the LED. The final port was then done with 5 into 8 millimeter non-compliant balloon. And this was the final result after doing the final port. So as you can see in this picture, that the stent was well apposed and there was no residual disease. The patient remained well afterwards, and he was pain-free, and there was no complications after the procedure. The IABP was removed on the same day, and he was discharged on the third day of admission. So the take-home messages are that it's never too late and it's never too old for the percutaneous intervention. Like in this case, he was a terminally ill patient with metastatic malignancy, and he had presented to us with acute coronary syndrome. And the family was also insisting, so we had to undergo this complex high-risk procedure in this terminally ill patient. So this can be contemplated if indicated, and it's a very viable alternative to CABG in high prohibitive risk cases. I thank you all for your patient listening.